I am employed by Sauk Valley Voices of Recovery. Sauk Valley Voices of Recovery is employed by the state of Illinois. And we are so blessed to be so. And we do everything to keep that going, including try to get our reports in on time and make them make sense. How we doing, Joanna? But it is an honor to work for you guys and with you guys. And it is the bigger honor that the director, Laura Garcia, is elected to come in person to speak to you about the state of recovery in Illinois.
Good morning, everyone. I am going to just let you know right away that I'm really bad at technology, so I might struggle with talking and moving the slides. So again, I'm Laura Garcia. I'm the director for the Division of Substance Use Prevention and Recovery here in the Department of Human Services. And for those of you that I have the privilege to meet for the first time today, or hear about SUPR, we are the single state authority for the state of Illinois on intervention, prevention, and treatment and recovery services in Illinois. And we are so committed to recovery, and we've been working towards really understanding our position within the continuum of care, particularly recovery. We used to call ourselves DASA, the Division of Alcohol and Substance Abuse, and all of our funding was for treatment and intervention services, some prevention, but recovery wasn't part of our portfolio. So we have changed our name. It's pretty cool, it's SUPR, but it really, the R stands for recovery. So I am going to, before I move on to the next slides, I just want to share with you that often when you hear about government, when you think, most of us, when we think about government, we think about agencies that are detached from the community, that don't really understand what's going on, and that often is the case, unfortunately. But I just want to share with you that, yes, we have staff here from SUPR, Joanna, and Joanna is part of one of our units dedicated to recovery. And what we have done internally is really help all our staff of over 100 public servants understand that every decision we make is going to lead to someone receiving services and potentially saving or losing their lives. And so our staff are truly committed to bringing the resources that people need to recover from this disease. So I'm going to go through a couple of slides, but I just want to also thank I think it was Sammy. It's hard to follow Sammy, Mike. That was such an impactful story, right? But you do have to I do want to share so many things with you today in terms of what we're doing in the state of Illinois, in the state, our state agency. We manage, last year our budget was a little over, the appropriation was a little over $600 million dedicated to this field. Part of that money is the money that we're managing for the opioid settlement funding, 55% of that fund. We also manage the cannabis tax revenue. We manage GRF, and there's a couple of other different pots of funding. All of those, again, are dedicated to intervention, prevention, treatment, and recovery support services. So I also want to thank, before I get into some of the slides, I also want to personally thank the Northern Illinois Recovery Con event coordinators, the volunteers, all of the presenters, your dedication, your drive. I mean, I was listening to Tammy's story earlier. It is really how we connect as human beings to the pain that many of us unfortunately have shared, right? But also the idea that there is hope, that people do recover. So if we believe that recovery is possible, then we must remove all the barriers for people to access recovery. So people can make positive changes at any stage of their recovery, even if they continue to use drugs. The fact that somebody is using drugs and still calling someone to say I'm not doing well, I think I'm gonna die, it's still a step towards recovery. So we have to acknowledge that people may be in very different stages of their recovery. Some may start the process through abstinence because that's the only thing that works for them. And it's very clear, if I'm near someone who uses, if I even see images of syringes, I'm going to use, and they need to focus towards abstinence. Other people have different paths, and so as we move towards this process, for the state of Illinois, all forms of recovery are valid to us. We don't want to discourage people from continuing the conversation about recovery, especially early on. And so we used to, in our system, we used to say, in order for you to come into treatment, you have to stop using drugs. Now that we understand recovery a little bit better, because we don't fully understand every pathway of recovery, does that make sense to tell someone who's using heroin, stop using so you can come into treatment? Stop using alcohol so you can come into treatment. Well, again, if they could do it on their own, they wouldn't need us, right? So it's important to acknowledge that even asking for help is a step towards recovery. So we're sharing this, and it's just because all the way from my office to our administration, the governor's office, all the way to the federal government, recovery is a key component in our portfolio. Now, our mission is to provide a recovery-oriented system of care along the continuum of prevention, intervention, treatment, and recovery supports, where individuals with substance use, those at risk, and are valued and treated with dignity, and where we can eliminate the stigma and accompanying attitudes and discrimination and any barrier to recovery. We used to treat, we are moving towards an area that I'm excited to share with you. You guys have probably heard about medication-assisted recovery, right? We support medication-assisted recovery. We're excited because it used to be almost taboo for someone to say, well, the doctor said I can explore medication to start my recovery. And I worked in the field of substance use for over 20 years. I was a counselor, I was a supervisor, I was a director, and we would always say, oh, no, you have to stop taking any medication in order for you to access our treatment. We want to eliminate that. So what does it mean to have a recovery-oriented community? It means that we recognize that the environment influences our well-being, that the community can promote recovery, and reduce the harms associated to substance use. In partnership with our communities, with you, we are normalizing recovery and destigmatizing substance use and mental health conditions. Now, I'm going to ask you just really quickly, how many of you believe that substance use disorders are medical conditions? Raise your hands. Excellent. Are you treating them as medical conditions? Are we treating them as medical conditions, right? Because when my husband has diabetes, and when my husband eats too many cupcakes, his doctor doesn't discharge him. His doctor doesn't say, you have to go to someone else because this isn't working. So we need to start asking those questions about, if we believe that substance use disorders are medical conditions, why do we give up on people so quickly? Why is it only on them to make the changes, right? And so sometimes we have to make sure that as we work together, we normalize the fact that recovery is possible, but these are medical conditions. We are elevating the voices of people with lived expertise because we have to. You can't, we have in medicine, we have heart specialists, we have psychiatrists, we also have to make sure that people with lived expertise are guiding our policies, are guiding the changes that we need to make to save more people. We are improving long-term outcomes, and we are also establishing holistic support for all people's families and the community impacted by substance use. I'm so proud of myself. I'm doing really well with the slides, though. Once again, thank you for inviting me here today to share with you some of the initiatives that we have implemented through our office to support recovery efforts. we are growing along with you. So the first initiative I want to share with you is that we have always required the American Society of Addiction Medicine criteria in the state of Illinois for our treatment providers. We have required the ASAM because we believe that substance use disorders are medical conditions and that require specialized support that are culturally informed and also trauma informed. And so we've required for a very, very, very long time, almost over 30 years, I believe. I'm very happy to share with you today that we were on the right path even 30 years ago, because the ASAM criteria looks at many different dimensions of a person's life, and one of them has always been relapse potential. We used to call it relapse potential. It has changed now. It's in its 4th edition. But it has always looked at the community component. It has looked at the medical components, risk for withdrawal, and all of those wonderful things, right? I'm very happy to share with you today that we have distributed the ASAM book to all of our treatment providers. But what we're excited about is we're going to be moving into the training and understanding that ASAM, the American Society of Addiction Medicine, now recognizes the importance of addressing harm reduction, because you cannot recover if you die, right? Bottom line. That social determinants of health play a role in you developing a substance use disorder and also play a role in your recovery. If you're homeless and somebody's telling you all you have to focus on is just not using, but when you leave the treatment center or the recovery center, you're going to sleep under a bridge, how do you recover, right? The importance of using cultural humble or culturally informed services. Our culture, we all have a culture, right, and language are often resiliency factors, and we need to help people begin to identify those resiliency factors within their homes, within their family, or within their communities, or start building them. And the importance of trauma-informed practices, because trauma is a key component to substance use disorder. Sorry. Oh, God, I was on a roll, right? Trauma is a key component in terms of recovery, and also they are now recognizing recovery support services as a distinct service within the treatment continuum. Also, as of October 1st, the Medicaid HFS, the Health and Family Systems Department, they are now paying for recovery support services within the treatment system. So again, connecting that substance use is a medical condition. The American Society recognizes it's a medical condition that includes recovery support services, and Medicaid is not going to pay for these services within the treatment community. The other initiative that many of you probably know better even than me is our Access Narcan project. The Access Narcan project provides access to naloxone to community organizations, law enforcement, and other organizations that need to have access to this life-saving medications to restore a person's breathing when they're overdosing. Most insurers now cover Narcan, and also it is now available over the counter. And we're looking into, how does this state align with the fact that the Medicaid now covers it, and it's now available over the counter, so we can start thinking about long-term sustainability plan for our organizations to make it available to everyone they treat. We believe that every doctor who is seeing people with health conditions, they might not be there for a substance use problem, but they should be asking the questions. If you are you using substance? And if somebody says, yes, I'm using, that doctors should be sharing Narcan with them, or at least prescribing Narcan so that when they fill their prescriptions. This is our drug overdose prevention program. The QR codes, again, many of you probably are very aware of this program. This is how you register to become a DOP program. And once you're enrolled as a DOP program, you can order Narcan at no cost so that you can distribute it in the community. We're really excited that through our DOP programs, we have law enforcement, we have many, many different programs. Many health departments are also ordering it from the state. The other program that I want to share with you is our medication-assisted recovery. Medication-assisted recovery existed within our treatment field only as methadone. We were only promoting methadone as an option, and only an option for opiate use disorder, and I'm saying it was very limited options. Most people believed methadone still carries a very high, a lot of stigma, but medication-assisted recovery has been shown to be effective. In fact, when COVID occurred, we were very concerned that people who were in methadone clinics, who were going to get now 14 days supplies of methadone to take home, who would have been going there every day. We started to collect data to see, what are people going to do with the methadone? Or is there going to be a higher risk of people overdosing or diverting the medication? So we started to collect how many people overdosing in our methadone clinics. We started to collect how many people is there diversion. And I'm very happy to share with you that what we found is that what we believed was completely wrong. Very few people that were in our methadone clinics overdose with methadone. Not to say they might not have overdosed, when we were collecting that data, the numbers were still, we're talking about over 14,000 people in our methadone clinics during COVID. We were seeing the number of overdoses were 2, 1 a week. Sometimes in a month, sometimes we had 2 people. So we learned a lot with that. So MAR was the expansion of medication-assisted recovery. What MAR is that people now have access to call our helpline, our state helpline, and they can request, if they say, I'm looking for services for an opiate use disorder, I'm using heroin, or I'm using alcohol. The staff answering the phone on the other side on our helpline will ask them if they're interested in medication to treat their condition, and if they say yes, they're connected to our MAR provider. They get a call, they connect them directly, or they get a call back within 72 hours. And we have physicians that then speak to the person over the phone and are able to get them started on a consultation. But many of them are prescribing buprenorphine after doing the screening. And people are starting their medication once they get onto the pharmacist to fill their prescription. They're starting their medication to treat their opiate use disorder. Now we're tracking this very closely because, again, we want to make sure that we wanted to make sure that we weren't establishing a system where people are getting buprenorphine and they may be diverting, and that really was not our concern. What our concern was, are we increasing the risk of overdose? And we are not. It has actually been very, very effective. And so we're excited, and we want to make sure that our community members can see that, that this is also a pathway to recovery. When they call, not only do they get connected to a physician so that they can begin MAR, they also get connected to a recovery support specialist. I think they call them case coordinator. And they then, if they need help with housing, if they need help with food, if they need help with other resources, transportation is a key factor in this program, they also get connected. This is our helpline, and if you have never visited our helpline is the statewide resource to find treatment and support for opiate use disorder and all other substances. Every one of our licensed programs and our recovery programs are in this database, and so when someone calls looking for a recovery home, and if you call us and tell us where's the best way for me to send someone to find help, we're going to give you the helpline. Because it's a centralized point for resources, not only for substance use, but also for gambling, and now MAR. Just to give you an idea, since we started the helpline, I think in 2019, over 160,000 people have called, just called. Our website searches, I believe, are triple that number. So the other thing, this is our learning collaborative in jails. One of the populations that is at very high risk for overdosing is the population who's involved in the criminal justice system. So we started to look at what options did we have, and we received specific funding we received state opioid response funding, and with that funding, we established a learning collaborative so that we can then work directly with the county jails, because what we were noticing is when people were being detained in the county jails, they were being taken off their buprenorphine or being taken off their methadone. Well, when those individuals are released into the community, the risk of relapse is incredibly high. So we also noticed that this was a key opportunity for the county jails to start engaging people in treatment. Again, if these are medical conditions, if somebody walks into a county jail and they report that they have asthma and they need an inhaler and they don't have one, they should receive one, right? Because people need an inhaler. So we established this learning collaborative, and it's been an incredible project. So what they are doing is that they're meeting with professionals and starting to really, 10 minutes. Okay. So people who come into the county jails that are participating don't have to stop using for example, their methadone. The county jails that have now implemented MAR, they now have protocols to support people so that they can continue their methadone or buprenorphine or other medications for alcohol. They can also, if they're interested, they're connected to MAR now, or they're connected to their own medical practitioners so that they can begin buprenorphine, or they're released and connected to a methadone clinic or to a physician so that they can continue their medication. So it's really engaging now the county jails and saying, you're law enforcement, we're focused on treatment, but we're seeing the same people and there's a gap. And now there's a bridge between a person being detained all the way to them maybe entering treatment after they leave the county. Now, the next graph what I want to show you is that it is working. These are the number of, this is the percentage of people that are entering the county jails and continuing treatment after they leave the county jails continue to increase. We're up to, I think, over 1,000 people that otherwise would have left the county jails with no treatment, no support, no medication to treat their disorder. So the MAR County Jails program is, right now the active counties represent about 57% of the state's population. This is incredible. We used to work in silos. The criminal justice system was over here, treatment was over here, recovery really was at that time 12-step programs only, was over here, and very small. Other grassroots organizations were not really starting to bridge those. We're all starting to work together to address substance use disorder, which is really wonderful. Now, we still have a lot to do. I don't want to bring all of this information to you and say, hey, this is the wonderful thing we're doing. We're on a good, we have so much more to do. Just in regards to treatment, the federal government has identified that over 36.8% of people that have a substance use disorder did not seek treatment. And so when we start to look at the numbers in terms of people who are being identified who have substance use problems entering our system, we're seeing that there's still a lot of challenges. There are many reasons that they have identified why people are not seeking treatment or going to recovery support programs. One of them is that they think they should be able to handle their substance. They should be able to handle what's going on in their life. At the same time, this is a key component for us because we also have to start changing our approach to substance use disorders, as I shared earlier. We also have to stop, at least with the state, we cannot make people responsible for their own conditions. So if people believe that they should be able to handle their disorder, it may be because we are constantly, at least, again, I come from the provider system, constantly reinforcing the idea that when someone cannot stop using drugs, they don't want treatment or they don't want help. And the recovery community has done an exceptional job in helping us move the needle in that. And really, you guys have just done an exceptional job. That's all I'm going to say. I'm going to speed it up a little bit more because I know we're almost there. These are the maps of the recovery partners from as of September 2024. As you can see, they're pretty. We still have some areas, but I have to tell you, when I started in 2018 at Super, they were probably like 10 dots. So we have a couple of specific recovery support programs. We have the recovery support services that we started paying with block grants funding in 2020, and now Medicaid is going to pay, and we're working to continue to expand those services. We're really excited that Medicaid is going to be paying because that will bring a lot of sustainability for the treatment programs. It will also help us kind of see where the gaps are. So we will continue to pay for recovery support services before treatment and after treatment and during treatment for those that are uninsured. Then we have our recovery community organizations, and I'm not going to say too much about those because you guys are, I think most of you are RCOs or Ross in this room. We have 30 RCOs, we have 40, and then we have 43 recovery-oriented systems of care. From this slide, you will see grant-funded recovery support services. I'm sorry, I lost my space for a minute. So Super allocates just over $13.7 million in block grant funds for RCOs and recovery support services, funding over 30 different agencies and serving over 53 counties. About half of the RSS provider service hours are split between recovery and peer coaching, community outreach and engagement, and harm reduction. They also support people's recovery by assisting them with transportation, with some of the social determinants of health that, if not addressed, would really create a barrier for people to recover. We also have partnered with Oxford Houses, and so we first partnered with them in fiscal year 22, starting with a total of 58 houses in 19 counties across the state. And Oxford Houses embrace a wraparound approach to recovery. We're really excited to see that this year they opened their 100th Oxford Recovery House or Oxford House in Illinois. That means we have 850 beds in Oxford Houses in Illinois. And then our licensed recovery homes that have been in existence for over 30 years. These are safe places for people to continue their recovery after maybe an inpatient program or after they're leaving the criminal justice system. These are very low barrier recovery programs because the state only requires that you participate in 5 community groups per week. And that might not even, is it 5? No, I think it's lower than that. I think it's even lower than that. Because we believe that recovery homes should be family-like environments. They should be really helping people start to live within an environment where they feel safe, where they feel that they're with family, and that, again, it's a family-like environment, but it's a healthy family-like environment. Then I just want to share with you that we also, in the last couple of years, we started to recognize that we had to play a role in the permanent supportive housing arena because people with substance use disorders, actually most people that are homeless either have a substance use disorder or a mental health condition. And so we started to we released a NOFO for a permanent supportive housing project. It's still a pilot because this is new for us, but we have housed over 300 people in this permanent supportive housing. It's a housing first model, which means that if you relapse, you're not going to be kicked out of your own apartment. This is your apartment. So, but we also provide wraparound services like case management, treatment, and other services that are needed for people to be able to stay in their housing. We also are very happy to create awareness with you, join you, especially during Recovery Month in September with Joanna's and her partners. We lit the sky purple, and we were very proud to see that. Joanna took these pictures, by the way. We are always super excited for September to see the skylight in Chicago turn purple so that people can start to ask questions. Internally, we were very proud to change our screens and wear purple colors so that when we were in every meeting, people could look at our backgrounds and just ask us questions. What is that about? Why do you guys all have that purple screen? But as you can see up there, it says Recovery Month belongs in Illinois. And then these are some of the pictures of our RCOs and ROSC and how they participated. Thank you so much for sending them to Super. We just wanted to share them with you today. So here's another one. I think I'm over time now, so I'm just going to go really quickly. There you go. So the last thing I just want to share with you is that we are very grateful for your partnership. We believe that recovery does belong in Illinois. It is possible, and people can achieve it if we give them the right sources and not give up on them. So thank you so much for allowing me that.
I had built into the schedule about 5 minutes for question and answer. So if anybody has any questions, give her my back for about 5 minutes.
So if we are trying to connect clients, so I do a lot of household outreach in the west side of Chicago. If we're trying, my biggest struggle is that initial contact where it's like they're crying, they want help, but then actually getting them into treatment. It's just that heartbreaking moment. So you mentioned like houselessness, some of these pilot programs. How do we connect directly with those programs?
So we would encourage you to connect this person to our helpline, because our helpline can then talk to them about what options they have, and if they're only looking for housing, it's going to take a minute, because we all know we have a housing crisis, right? But what they will do is they will search the database and start to see if there are recovery homes available that could be near where the person lives, to see if that's an option. They also, if they're actively using, they might connect them to a program that has an inpatient treatment program and see if they're able to get into, to complete an assessment and enter the treatment program. So there are different options for them. In regards to the permanent supportive housing, we don't have a pathway yet, because we're very fortunate that people are not moving out, so we have limited beds. However, we work very closely with the Chief Bureau of Housing, Christine Haley, and we can always connect with them to see how can we get this person into the continuums of care for an assessment to get on the path of permanent supportive housing. But the helpline really is the key for us.
You had a question over here.
Yes.
So the slide itself contained a lot of great resource information. Would you be willing to share that slide with us?
Absolutely. Yes, absolutely. You can share it. We'll share the slide, and we can also share contact information if you have direct questions. Yes.
I just applaud your efforts for developing that sustainable building mechanism that's been requested for a long time, and I'm super appreciative of your empathy. To that point, we have 25 or so recovery support specialists that we work with, and their diversity in job function is great. Mm-hmm. And so can you define for me a little bit that scope of service that is covered by Medicaid? Like, is it street outreach? Is it more coaching, what is kind of that civil service?
Yes, so happy to do it, but I can also share with you the Smart Alert that we released that describes and also includes some of the information from HFS. We worked very closely with them, and so the services that can be billed to Medicaid have to be services for a patient that is in treatment. The recovery support services are broad. In fact, in the release that we're about to share with you, actually we haven't released the Smart Alert yet, no we have not. And the reason for that is we really want to be very mindful that if you look at our old webpage in the definition of recovery support services, it was very specific. There was a list of like 10 things that they could do. So again, working with you, we realized, why do we only have 10? There could be 50, right? So we are broadening the definition so that we can make sure that if somebody walks into your facility and they say, I need recovery support services and I need treatment, and you determine that they do, then they can get both. But they guide the services for recovery support. So it could be job training, it could be like the development of a curriculum, it could be coaching, it could be going with them to a visit for DCFS because they're trying to get their children back. The patient really should define what those recovery support services are. There will be some limitations for sure because we want to make sure that they're distinct services from treatment, from education, didactic groups, but we're broadening the scope of work. Yeah, absolutely. Sure, absolutely. Anything else?
I think a good tagline would be purple rings.
Thank you so much. Thank